Hello, everyone. Thank you so much for joining us. We are here today with a renewed hope for healthy, smart cities and rural health. I'm Heather Flannery. I'm your host, and I'm the Chief Executive Officer at AI MINDSystems Foundation. We're so pleased you could join us. I am here with two esteemed panelists, and we've got some very exciting and interesting news to unpack today. Before we get started, we will have a Q&A session at the end. Please feel free to enter any questions you have in the Q&A dialog box on the Zoom client if you're with us on Zoom. And with that, let's go ahead and get started. I'd like to first introduce our panelists. Let's begin with you, Ryan. Um, Tell us about your role and activities with AI MINDSystems and a little bit about yourself.
Absolutely. Thank you. Yeah. So I'm here from Vermont, or living up here in Vermont in White River Junction. I am here as an advisor to help support our interest in sustainable infrastructure and bringing together strategic partnerships, in particular as well in my local community, working toward implementing the Wisdom Network in the geography of Vermont. So one of our geographic wisdom networks. And ultimately here to connect the dots across the needs of healthcare, education, and the prosperity initiative of AI MINDSystems.
Thank you so much, Ryan. It's terrific having you. And you're representing the infrastructural dimensions of achieving a vision of a greatly improved set of rural health and in urban circumstances is such a wonderful thing. I am excited to tell you that there is late breaking news that we are announcing just right now on this live stream and in this event. AI MINDSystems Foundation has a new leader who has just joined our team. I'm going to be asking him to introduce himself in a moment, Dr. Jordan Orley. The organization has decided to make occupational and environmental health a top priority and to form a new kind of utility that we call wisdom networks, focused on innovation and distribution of innovations in that field. Dr. Orley is our Vice President of Medical Affairs for Occupational and Environmental Health. And in this new utility, the Occupational and Environmental Health Wisdom Network, he will serve as its president and chief medical officer. From all of us at AI MINDSystems Foundation, Dr. Orley, welcome aboard. We are so thrilled to have you. And I can't wait for you to introduce yourself to the world. Over to you.
Thank you, Heather. And I'm very excited to begin my new role at AI MINDSystems. And what a visionary company it is. And together with my company, Combat Compensation, I'm really looking forward to this joint ventureship and starting to create what will amount to a technology that will help, hopefully, tens of thousands, if not millions of veterans around the country and help them achieve their benefits that they so rightfully deserve. So I'd like to begin by just giving a bit of background about myself. It's been a long road and journey in the field of workers' compensation and as an independent medical examiner, where I've been working for several prime contractors for the VA for the past 8 years. I've met with 8,000 veterans in that time, and I've written close to 6,000 medical legal opinions, also known as nexus letters. And I've come to understand veterans' plights and really gained a lot of insight about how veterans see and experience the world of workers' compensation and some of the travails and the difficulties that they face in gaining benefits. So when veterans are injured in the service and they have conditions that are related to service, they have to have an examiner, usually a medical doctor, examine them, do a physical exam and a history, and then make a determination whether their condition is due to service. And this is very fraught because it is based on medical records that have to be reviewed carefully by the examiner. And sometimes these will amount to several thousands of pages. And so it's very challenging for the examiner um, to do an adequate exam without the help of technology. And I think that's where AI will come into the picture here and 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 help us to create value for the veteran and for the VA in summarizing medical records, creating decision-making support for the examiner, and ultimately creating a more equitable process for workers' compensation for veterans. So I'm very excited to be here today and looking forward to having a nice chat about rural health and city AI in the development of cities, and looking forward to having that chat with Ryan and Pete and Heather. And so thank you so much for having me here today.
Thank you very much, Dr. Orley. So one of the things I'd like to connect as a dot first is those of you that follow AI MINDSystems Foundation know about the initiative that Dr. Orley was mentioning called National HERO. HERO is an acronym for Health Enhancing Resource Orchestration, and National HERO is also intended to evoke the target cohort of this initiative, who are active duty service members, veterans, first responders, and all of their immediate families. This population, both in geographic units and holistically, especially in the United States, is a top priority for us. And Dr. Orley's very deep experience in dealing with many specific veterans' health challenges that have to do with occupational and environmental hazard, injury, and exposure that has occurred in the line of duty, that those hazards and exposures and events also happen not only to veterans, but to other people all around this country, not at the same proportion. But the role of environmental health has a great deal to do with what we want to bring to our healthy, smart cities and rural health apparatus. So maybe one thing I would love to do to start is to connect this dot between population health generally in whether in a rural or urban area, and environmental exposures, toxins. Maybe you could give the audience a little bit of a basis in that, just a fundamental understanding. And then Ryan, it would be great to then lend a perspective about what kind of infrastructural interventions could aid in addressing, diagnosing, preventing those types of things. So with that, over to you, Dr. Orley.
It takes a tremendous amount of research to discover that a specific chemical or toxin is causing a disease or a variety of diseases. And that requires the aid of data scientists, epidemiologists, infectious disease experts, chemists, and anybody who's knowledgeable of biohazards and military waste. And so it takes decades of research, and also there's the element of the political element as well. So, for instance, Agent Orange. Now, it was recognized that Agent Orange was toxic to humans even before it was utilized in Vietnam. Yet it took decades of research, epidemiological research, and collection of data of not only veterans, U.S. veterans, but also those who were affected in Vietnam, Vietnamese populations. And then also it took the recognition of the government to say there is an effect, and here is the list of conditions that are now recognized as related to Agent Orange. And so many veterans that I've seen with a variety of medical conditions, including diabetes, Parkinsonism, heart disease, will come and see me, and their conditions are related to Agent Orange automatically as long as they qualify under the requirements of the VA regulations. And so similarly, the PACT Act of 2022 was a long time in coming for airborne toxin exposures for veterans of the Middle East and the Gulf Wars uh, in Syria, Iraq, Iran, uh, and Kuwait and those regions. So it's really wonderful that things are starting to move more quickly. Like for instance, in Camp Lejeune, you're starting to see things, gain traction, and now those veterans are receiving compensation. And so the time from recognition of the toxin to the time of compensation for exposure to the toxin is shortening, which is a great thing for veterans who oftentimes are whose life expectancy is shortened, and so therefore they need that compensation more quickly, and rightfully so.
And I'll jump in. So for starters too, I want to point out the complementary sort of challenges and benefits of this informational piece, right? Is the information that we're gaining from these military personnel contributes to the overall health and wellness of the rest of the population, right? As we learn about a problem in one population, we can then apply that to other populations. On the other hand, we also have the challenges of, while we get things passed and we have services implemented for the VA for these service personnel, we don't necessarily have that happening in parallel with our at-home first responders, which have very similar needs. A firefighter is exposed to all kinds of toxins in the air. A first responder to a car accident is exposed to very gory, challenging events. And so those challenges are similar in their ways and complementary in the research and background that we have, but also the solution and service is delayed, sometimes years, and not in parallel because of the bureaucracy and the systems that we have, right? And then to the infrastructure piece, collecting that data. Infrastructure is not just bricks and mortar and fiber cables. It's also the bureaucracy and the people and the structures that we have in place to actually communicate that data, utilizing tools and technology. And so, as we come to this day and age, and we have, such an amazing level of technology available, we also still have in Vermont, I know the statistic is like 30% of people aren't connected to the internet or have an internet connected device. We also have individuals who are unable to advocate for themselves because of perhaps a disability or just that they're aging, and have, some impairment that prevents them from fully communicating what the issue is. And so in this way, we need to not only have the tools to put in the hands of individuals to support themselves, but also the tools to put in the hands of the community around them to support those individuals on a secondary or even tertiary level of people in their immediate family or community or service providers enabled with the technology like yourself, enabled with an AI tool to help you analyze thousands of pages of records in order to make an efficient, effective result. And so, we have challenges all over this country where we need internet to people's homes. We need the service providers in any area, whether it's in the middle of an urban setting or out in a rural setting, to have the same level of device capacity, connectivity, compute, and data resource to serve the person or the constituency in front of them. And so this is a challenge that we've been experiencing in this country for quite a long time, and we're making a lot of really good progress on these things. And it's really on all of us, I think, in many ways to participate in the process and advocate for the tools and services that maybe we don't personally need today, but we as a society continue to need and grow with.
Mhm. Yeah,
Yeah.
and I want to second that thought on advocacy, because I think that's fundamentally what our project here is about. Our joint ventureship is advocating on behalf of veterans who are generally not knowledgeable about how workers' compensation systems work and the need for uh, detailed summaries and data to back up their claims. And so similarly to what you mentioned about firefighters, uh, firefighters are have amongst the highest exposures to chemical toxins amongst any profession um, in the country. And fortunately, though, for firefighters, many of them are acutely aware of those exposures. But veterans are often in the dark about the exposures that they have experienced. And so I think it's important to bring that to light through not only geographically looking at where they were located during their service, but also looking at the data contained within their medical records that might hint to an underlying asthma, for instance, like a reactive airway disease that might be undiagnosed. So it's not always so evident in the medical record if there isn't a diagnosis, but there may be the signs and symptoms of a diagnosis hidden in there that can eventually lead to a diagnosis by an examiner who's an astute examiner, and then eventually compensation for that injury or illness.
Mhm. I want to connect a dot about our bigger picture approach to give the context that we're discussing here uh, a little bit more depth. When we are talking about a new intervention that can affect occupational and environmental health, specifically in the context of achieving a healthier, smarter city and a healthier rural population, what we're talking about is creating a new kind of utility that serves multiple stakeholder groups, individual people, government agencies, private corporations, health insurance providers, payers, et cetera, with a new kind of data and AI infrastructure. And the individual people also participate in that infrastructure, and each individual person becomes an endpoint for validated, verifiable data and input, and the ability to have much further reaching deep integration into a community and a physical space through all of the different kinds of sensors and data sources that can be activated and aggregated through an individual as in an infrastructure perspective you would describe as a trusted endpoint. So this implicates everything from disease surveillance to prevention policy and strategy to affecting access to diagnostics, treatments on an emergency basis, on a non-emergent basis. And that AI Mind Systems is working on the creation of this new kind of utility and the creation of the way that a human being becomes an empowered endpoint in that data and AI apparatus in a way that preserves their privacy and their dignity in that participation. So that's the bigger picture construct here. And as we announced at the beginning, we are now creating one of these utilities that will span all geographies and support specifically environmental and occupational health features and capabilities and innovations being deployed into every geographically organized network. And it looks like you wanted to comment on that, Dr. Orley, or perhaps I didn't want to, go ahead and interrupt. It's okay.
Yeah, in terms of the geographical components of workers' compensation, which is the field that I know the most about. You know, there's veterans in each state that are exposed to state by statewide uh, um, types of types of exposures. It could be heat in Texas, and it could be dust in New Mexico. And so I think it's very important to aggregate that data and to understand, where are these exposures occurring? How is it impacting individuals? I mean, you're pushing these young men and women that are beginning service generally at age, 18 to 21, 22, to their extremes, in basic training and beyond. And the question is, what impact is that having on their health in the long term? And if we can track that, beginning with where they started basic training and go from there in a longitudinal way and in a retrospective manner as well, then that will create just a plethora of data and information that could be, utilized to predict where disease will occur amongst veterans and when, in terms of at what age. You're seeing veterans, that are affected by conditions that really have no explanation at very young ages in their 30s and 40s, that are considered, autoimmune diseases, fibromyalgia type conditions, that involve muscle aches and headaches and all sorts of other types of conditions that and or symptoms that just don't have any real quantifiable reason. And so we really do need to look more carefully at the data and try to understand that and try to, most importantly, prevent these conditions at the outset. Why are these occurring, and then going from there. And there's a lot of similarities between that and rural health. I'm sure Ryan, and smart cities. I'm sure Ryan could touch upon that further.
Yeah, and I think that's the vision, right, of being able to take the occupational sort of domain specific wisdom network and then dial it down into the various regions, right? Every region has their own entities and institutions, hospital systems, regulations. And one of the I think biggest opportunities is to be able to take this data and correlate it with other general population data in order to generate the focus and demonstrate the ROI on having a focus on outcomes, right? And recognizing that, sometimes you don't see it if you're not looking. And so if we have this population data that tells us, hey, heat is creating this kind of issue, this chemical exposure is creating this kind of issue. Like you said, sometimes you don't have those red flags that just jump right out as a diagnosis for an individual from any population. But if you can start to recognize the environmental correlations that say, hey, if people were in this environment, we should be looking for something in particular. Or if this person in this environment is demonstrating this risk or this symptom, there's probably other people in that environment that aren't necessarily reporting it, but are also experiencing that. And so that can bring us to another level of public health. And there's differences in that rural versus urban environment. But one of the biggest differences is that many rural individuals don't have easy access to their healthcare system. They have to travel much farther to get to it. They don't have as often an interaction with the healthcare system, and they're not connected with as many people in general in their social circles. So they might not get triggered to go seek some kind of medical professional when something is happening. And so the more we can narrow that gap, level that playing field, if you will, as well as articulate to the other stakeholders, the insurance companies, the state regulators, the employers, and anyone who has an interest in having healthier people, whether it's for the sake of lower costs or the sake of better employee performance, all of those things having a focus on outcomes allows us to eliminate some of these delineations between urban and rural, or civilian versus service members. We're all people, we're all humans, and there's a huge benefit the more we're able to work together on the data to be able to benefit everyone in the population. So this opportunity to service our service members and thank them for their service by putting a spotlight on the things that we can to improve their health allows us to magnify those results and have that impact on every other human in our communities.
Yeah, and I agree
Oh,
with you. I agree with you that we can extrapolate a lot of information from veteran health to the general population and rural populations and immigrant populations and underserved populations. I'm currently a student, master's student of public health at the University of North Carolina in Chapel Hill, and I recently wrote a paper on veteran loneliness and isolation, social isolation, which is a major issue. The Surgeon General put out a warning last year that it was a major public health crisis. And uh, it's really not just an issue for veterans, although it does acutely affect them um, at higher rates than the general population, but it affects people across the population. And so taking information from veteran health and generalizing it to the greater population can be really helpful. And just wanted to mention about healthcare, or excuse me, insurance agencies and companies. The VA and healthcare agencies, they are the ones that really, in a way, have the control over veterans and others' medical charts, medical information, and by moving that information into the hands of veterans, into the hands of patients, and empowering them to understand what's in their medical records, kind of like somebody who wears a bracelet with their information on it that has their blood type, in case of emergencies. Similarly, that information could be so valuable to people who are going to the doctor, and they are able to tell their entire life history, on a data chip that they provide to their doctor, and the doctor can pull it up and say, "Oh, okay, now I know, what's going on with you, what your medical history is." And that's in essence, what we're trying to do here in terms of the project that I'm going to be working on with AI Mind Systems. Is we're trying to basically shift the data from the VA over to the veteran to help the examiner and to help the VA to make the process more efficient and more equitable. Heather?
thank you. Yeah, I would love to build on this in a couple of important ways. Um, so for example, the VA custodies a tremendous amount of data about their veteran patient population. But I think it's very important to remember that there is no location where all of the information about any one of us lives. And when we're talking about discovery within extreme complexity and dynamism, we're talking about ideally needing to have not only the infrastructure solutions, but the analytical capabilities to do that across potentially thousands of data silos. And what the VA could never do is compute on all the data about their data subjects that is not under their custody and that they did not originate. And is there some level of data sharing that goes back and forth? Yes. But even that is only in medical records per se, formal medical records. When we're thinking about environmental and occupational health, as well as mental health and other and social determinants of health, the germane information is generally not in a formal medical record. In fact, in the case of veterans, it's so much about their service history that informs that, just as a for instance. So a key factor in how we're approaching this is that to use AI to its fullest effect for scenarios that are prioritizing precision over generalizability, precision about one person as opposed to a model that is most generalizable to all. That's a different data acquisition requirement. It's not about getting the largest series size of a common record type. It's about getting as many data domains about the same data subject as possible and available scientifically, clinically, analytically, and to train and use models at runtime. And another really important point of all of this is it's sort of, if you didn't know differently, you would assume that we're saying, let's get all of the data in the universe and put it in one enormous data warehouse, like the ideal data warehouse that is so enormous that we could answer every question through it. In our model, oh, go
I said
ahead, right?
they're trying to do that already. Like that's the simple answer
Yes,
that our brains go to as humans. And there's lots of organizations already trying to do that. Hospitals have their silos of data and they're trying to break down those silos, but the way they're breaking them down is making bigger silos, right? And
exactly
and
right.
it just it's exciting to think of what we're capable of now because we do have these powerful devices in our hands. We also have the capability of deploying powerful devices in our environment, in our public environment, in our private environments, and relatively non-invasively too. You know, you can have an elderly person that maybe they don't want anything to do with tech, but you could have a little device on the wall that could detect if they fell down, could detect if their breathing rate changes, can keep that information for the sake of their own personal record, but also for the sake of an emergency response need that can be even more rapid than waiting for somebody to get a phone call. And then on top of that, we have the ability to isolate that data with the individual, right? So we need it backed up and resilient. So it needs to be sort of in the digital ecosystem, but it needs to be accessible only by that individual and their trusted counterparts, right? Their trusted doctor, maybe a trusted family member, and that data should be owned and held by them, and it can be now. We have that capability to do that, and so that's what's really exciting about what AI Mind Systems is doing and what our technology is capable of doing is interconnecting that history with the current present day data sets between what we can get from the individual directly and what we can get from various environmental indicators through IoT devices and things that can be out there that really allow us to stand up for ourselves and our needs and wellness.
Mhm. Yeah. It
Yeah.
takes individual people to represent themselves in the best possible light in different scenarios. When you go to the doctor, you play what's called a sick role, and this has been shown, through studies that, you're basically you basically somewhat exaggerate your symptoms. And the reason this is happening is because uh, doctors are not really looking that carefully or as carefully as they should be at medical records because they're just so extensive and they just don't have the wherewithal. And so just a lot of things are being overlooked at the medical doctor's office, and not only there but also within the realm of workers' compensation as well. So the reality is that examiners like myself are required to review thousands of medical records for each veteran, and we're seeing sometimes up to 10, 15 veterans per day. And it's just not realistic to expect a person to review, 20, 30,000 pages of records. And so it kind of brings me back to where I even came up with the concept to use AI in this field of mine, which is that I hired a scribe, and she would go into the medical records and she would create medical summaries for me for each veteran. So I could review the summaries prior to meeting with each veteran. So I knew what I was going to be talking to them about and what the important salient points were. And so it was interesting that that's how it all came about. And um, full circle, here we are today, looking at the possibility of affecting the review of medical records for millions of veterans. There are 4.3 million veteran exams for disability that are um, uh, that are done each year for the 19 million veterans in the country. And that number is growing by 15-20% per year. And the average veteran is um, getting $22,000 of compensation per year. So there's a lot at stake for veterans. And, I know veterans who have asked me to review their medical records, and I've done so, by hand. But it would be great to have a technology that we're working on that can do so much more efficiently and more accurately, and drawing insights from VA rules and regulations. So yeah, I'm excited, very excited for this new technology to take hold.
Yeah, it's an interesting pattern that we see repeating in a number of ways. The pattern being the data that is necessary to inform some kind of complex decision is disparate, siloed, and extensive. And the administrative work of identifying it, finding it, and then the analytical work of consuming it and creating insights from it tends to be highly manual, highly inefficient. And then there tend to be specific outputs that need to be created. Sometimes these are certain templated documents that have to be created, and other times it's a certain workflow that has to be informed or executed. This very frequently occurring, again, 4.3 million times a year in the United States, this exercise is happening, uh, where it is completely dragged through the inertia of all of these steps that we're describing. And we now have the possibility to do it differently and to look at every other time that that pattern arises in and bring that capability to all people and all scenarios. Speaking of all people, I would love to highlight health disparities and health equity challenges, and maybe with a particular emphasis on rural health and what it means to live in a digital first health system without potentially any digital access, without technical literacy, without devices, without connectivity. Um, Ryan, maybe could you speak a little bit to what our Wisdom Network utilities, when brought into a geography, will do at that person-centered level, that individual family community level, and how actually maybe a couple of examples of pieces of technology or categories of technology that can be brought to bear so that we are not leaving big segments of our population behind in any cross section.
Yeah, yeah, absolutely. So, one thing is connectivity. We certainly need to be putting forth the research and data support, getting that connectivity out there. Many communities are pushing this initiative, but it simply does take time to build it. In the interim, we do have some pretty advanced wireless technology, satellite technology, mesh radio technologies that can help interconnect devices so that devices can get out to people. So even if they are folks that maybe aren't connected directly to the internet or don't want to be, there can still be the capability of either deploying, low-cost devices to be able to detect key pieces of information like air quality, like I mentioned earlier, respiration and other sort of fall detection types of technologies, but even getting tools in the hands of care providers, social workers, home nurses, anyone else that might be involved as a secondary human layer to servicing those end users to be equipped with the tools they need to collect as much data as possible so that their job is supported by the technology, but also serving the bigger picture of that individual person's overall wellness record, the picture of what it is to see them as a whole and treat them as a whole. And so there's a lot of different layers of this, right? We have to continue pushing infrastructure out. We also have to understand that not everybody wants necessarily what we think of as the best case scenario. And so we have to make the tools adaptable to the people, the communities, the ecosystems that are there to serve people. And then deeper in sort of the core of the infrastructure is interconnecting that rural doctor, that rural health worker, that rural teacher, educator, whoever it might be, or even family member with the broader capability of our world. And not just having that, one doctor being relied on to diagnose a particular scan or a particular piece of information, but being able to crowdsource that to the best minds in the world and be able to um, as best we can replicate that capability through technology so that every corner of our communities has access to the same level of diagnostic care across medical records, across any bits and pieces of information that we can collect.
I want to double click on one thing you said and make sure that the audience doesn't miss this one point. It's really critical. Everything that we've been describing in our nation in terms of broadband equity and inclusion and creating digital equity and all of that, it presupposes that the traditional telecommunications infrastructure that we've all been used to and relied upon, the only way that you can achieve that aim is by extending that very expensive, years to implement, original core infrastructure that cities rely upon into every other area. And this isn't just in our country. This same dynamic applies in low and middle income countries around the world, where the presupposition is that the way to achieve the aim is to do it the way it has been done, that the legacy built environment did it. But we have approaches that use other technologies that don't have to rely upon that process playing out in order to start to make digital health viable for all people vastly more immediately than waiting for fiber to be laid, for example. Can you just quickly comment on that? And that fine point, I think, is so important when we're talking about time to impact at scale.
Yeah, absolutely. So, I mean, the capability of mesh radio networks and software-defined radio networks has really come a long ways. And so that's where we have that capacity to do it with the tech we have today. It's been challenging because, frankly, it's much easier to centralize the cash flow through the way we have done it in the past. And so even our wireless technologies tend to focus on that centralized approach to connectivity. So if you're not in, range of a tower, you're not getting a signal. And, the mesh radio capabilities are very strong now. We just have to implement the business models and the ecosystem models that actually enable them financially. And part of it might be education for people to be able to utilize them. But device to device peer mesh networks are a very real possibility. And they don't necessarily need to, move a ton of data. They just need to move little bits of data that are key points, especially when we're talking about health. A lot of this stuff are small bits of data that get collected over time. So it's not huge chunks of data getting moved. When you're in the doctor's office, they're going to be pretty well connected and they're going to be able to grab the big data set that they need to do their job. But the little bits of interconnectivity that we need to really collect all the data necessary I mean, like LoRaWAN, for example, is a very broad-reaching, wide area networking, low power, wide area networking tool set that can collect on the open ocean like 40 kilometers. It can connect and collect little bits of data from a device. So that shortens a little bit in terrestrial environments, but still, that's a pretty substantial capacity to be able to connect with IoT devices, to collect key pieces of data in the environment around weather or home environments. And those capacities are very much real today, not to mention the ability to have, real functional internet connectivity through these mesh networks, especially in the case of rural areas that are just waiting for that better connectivity, or situations where there's an emergency where weather or some other event has cut off an area. They should still be relatively connected today. We should have those mesh networks set as a backup solution in any particular region.
Absolutely. And that is 100% consistent with our strategy. Thank you, Ryan. Dr. Orley, lots of healthcare implications, what was just expressed. I know you were eager to jump in here. Go ahead.
Well, the Internet of Things and all the technologies you guys discussed and is not necessarily my expertise. But I think that um, well, I think that, we all live in a shared environment here. We all live in either a city or in a rural area, and we all have unique needs, from a medical perspective. People in rural areas have reduced access because there's less practitioners out there. And there's unique needs for rural populations when it comes to healthcare. And so the technologies needed to address those needs are going to be different and unique. From my perspective, I think that rural veterans have certainly major challenges for not only receiving workers' compensation, but of course less access to health clinics, to the VA, which tends to be in more dense locations, and then of course their wait time for workers' compensation claim exams is going to be lengthier and delayed. So overall, I think there's a lot of parallels, and I'm excited to see how this technology unfolds, both in my field and in Ryan's from Ryan's perspective. So yeah.
We just got a great question from the audience that is really well suited to build on what you were just saying, Dr. Orley. You had mentioned earlier about individual patients representing themselves and their own interests effectively, and how hard that is, and that criticality of advocacy. I love if you could unpack a little bit more about your vision of how AI agents and AI generally can step into that advocacy role on behalf of all of us. And then maybe we need to unpack just a touch about how it's not the same thing if a corporation or government is operating AI and you're using it as a service, as opposed to AI that is running solely and strictly on your own data within your own control and has no conflict of interest, and how different that is, that we can be represented by our own AIs, just as corporations and governments will be hosting theirs in order to achieve their mission and aims. You have a vision where that advocacy of the person can be bundled to the person themselves through what we call self-sovereign AI. Maybe you could unpack a little bit more about how you see that working, and also how do you think veterans and other people that would use this technology would learn to trust it?
Yeah, great questions. So I think it comes down to really the voice, whose voice is being heard when it comes to the workers' compensation programs at the VA. So currently, the examiner dictates the conversation and asks the questions and notates the answers. The idea is to shift the control and the power of the conversation to the veteran and let them guide the conversation, let them uh, be their own advocate and also step up and have a voice in the conversation. So they know their medical records, they know the data in there. They're going into these exams prepared, and they're able to dictate for themselves what exactly needs to be expressed and to the examiner and what needs to be focused on. And so they understand, for instance, that um, the need for, let's say an imaging exam in a lung or respiratory disability benefit questionnaire worksheet, is vital. And they've had numerous, x-rays that the examiner may not know about. So they can mention that. So that's very important. I think veterans in general as a population are just to answer your final question, they're very wary when it comes to outside interference, and their data. They're very protective over their data because of the fact that they go through the military entrance processing station, which is where they are recruits, and that's their first foray into the military. So they have to be determined to be eligible for service. And so they learn early on to protect their data because if not, they could become ineligible for the service if they have a condition that's considered that doesn't allow them to enroll or to enlist. And so I think that's where it starts. So the question is, uh, how much sovereignty do they have over their data, and how do they maintain that autonomy over it? And so it's important that they know what's in their chart, they know what's in their, they know what is reflected in that information, and that it's not outside of their control, and the examiner just they're at the whim of the examiner, who may or may not perform an adequate record review. So a lot of now the basis of all of this is on the background of how the workers' compensation program even exists, and that is layer upon layer of laws over many, many years, over 100 years, that has created what is today the modern workers' compensation program. And ultimately, it disadvantages veterans who do not know what's in their medical records. And the reason I know this is because I have had numerous interactions with veterans who bring their summarized medical records to the exam. And when they do so, they are at a huge advantage, and they present to me that information, and I'm able to have a much higher level conversation with them about their medical conditions, and
Mhm.
therefore I'm able to notate the information from their chart, and I'm able to notate the information that they've given me uh, that has to do with their claim, and ultimately they're going to get a higher rating as a result of that. So there is a give and take when it comes to, veterans are going to have to uh, give up a little bit of autonomy of their data to gain autonomy of their data, and there's going
Mm.
to have to be that play, and it's going to be interesting how that's going to play out in the long term.
Yeah, that oh, go ahead, Ryan. Sorry.
Yeah, well, I was going to say, I like to play with language a little bit, and so I want to bring up kind of an old term that some folks may have heard, Big Brother, right? And that's an old term from a book. I won't dive into that right now, but it's a fun read. And one of the biggest points of that is who controls truth. And so I think military veterans, especially, having gone through that intake process, they also realize they kind of signed over a lot of rights that we take for granted in that process. And they've given them over to Big Brother, or what they might refer to as Big Brother. And, not to put that in a fully negative context, but it is just natural that, that system is there to protect and serve its mission, like you said earlier, not necessarily the individual mission of each person. And so a counter concept that I like to introduce to people where, they might not be super technical, some people are, some people aren't, and we can't expect everyone to dive into the weeds to understand how and why they should trust this, that, or the other thing. But I think what we can try to get across is that what we're building with AI mind systems and those within our cohort is little sister to counteract Big Brother, right? It's the little sister being your technology stack that serves you, your AI agent that serves you, your data set that serves you, but has the same power to create balance with that of what you might call Big Brother. And Big Brother in the past has been referring to the government, but any corporation is a very siloed organization of data and compute power, and they're applying it to their mission. And right now, in this very moment today, it's hard to imagine how we can individually compete with that. But if all of us collectively are individually competing with that with a set of tools that balances that power dynamic, then we can compete with that. And that's the thing that really has me hopeful in what we're building with AI mind systems and what technology is enabling people to do today is to provide that tool set that allows them to have little sister in their pocket in order to provide balance when they enter into any interaction with Big Brother, whether it's a corporation, government, the local town, their local doctor, local hospital, university, whoever it is, insurance companies, whoever it is that they have to interact with, they have that advocate in their pocket that has the same tools, the same power, same capacity as whoever's sitting on the other side of that table.
It's so well said, Ryan. And as we think about so many interactions that we have that can be data driven, they are often couched in a very friendly dynamic, but truly they are oppositional or adversarial in their very nature, in their design. And this notion of correcting a radical power asymmetry between what individuals possess and can do relative to what corporations and governments can do is profound in its implications. But what's amazing here is that 1984 was envisioning a dystopian future. We're talking about this re-empowerment and this re-instantiation of agency and dignity that is verifiable, enforceable, and provable now, not someday. These are technologies that exist right now, and they need to be put together in a very unique and specific way and then operated in a model that doesn't have a conflict of interest with the person. And, it's such an honor to have colleagues and collaborators like the two of you as we are moving down this mission. We do have a couple of questions I would love to take if we can get quick takes on these questions before we run out of time. One of them is about specifically in rural communities. Are there unique challenges that rural communities experience that require a different kind of ethical decision making and or ethical risk management? And I'd love just some quick thoughts from the frame of reference that ethics is all about choices. And then the bigger question is always who's empowered to make what choices and so on. How do you think as a public health practitioner and physician, how do you think about those ethical choices, Dr. Orley, when you're imagining a rural community, maybe with a variety of different disparities, exposures, et cetera?
Yeah, I think about equity in rural communities as a function of um, underrepresentation, um, as a function of people who have limited resources and are at a disadvantage already to begin with. And then oftentimes people who are disadvantaged are also discriminated against because of human nature. We tend to, kick people when they're down. So I think that it's just really it's not a matter of let's take the person out of the rural community and put them in an urban community. It's a matter of extending the technologies that are that we're using in urban communities and extending them to rural communities, but adapting them to the needs of the rural community and the specific requirements of, let's say, a less educated populace that just doesn't have the resources. So the ethics really comes down to what it really comes down to is oftentimes funding. Are we able to fund rural communities somewhat at the expense of wealthy urban communities? And you know and not deplete the resources of the rural communities that are already being utilized for, let's say, basic utilities or education, towards healthcare. And it's really sad that in today's day and age that rural communities are facing worse health outcomes and than urban communities. And so we need to really think about redistributing um, resources to rural communities. Mhm.
Thank you. Thank you for
Yeah.
that.
Yeah,
Ryan.
yeah, and I'll just jump in to say, I think that the real ethical challenge is you kind of articulated there really is it's the per capita cost of delivering a service and the per capita cost of localizing that service. Even if we think education wise, right? Like every kid deserves to learn about their community and their community's history. But if our AI agents are being trained on the world, then they get the impression that where there's more people, there's more importance. And so the information about that location seems more important on the surface. And similarly, when you look at costs, it looks like, boy, this looks like a real expense for us to get fiber out to every home, for us to, get, the same capacity of compute available to people in the locally accessible in a rural community as there is in an urban community. And it's that perception of cost and value that leads us to potentially unethical outcomes. And that's where we have to really be able to take a bigger picture approach and look at how important that rural community is to all of our population's health. There's a statistic, out that basically talking about loneliness, where being alone in a forested setting can combat loneliness, right? In other words, if those folks in the city had the opportunity to go for a hike in the woods, they might not feel so lonely and isolated, even though they're surrounded by people in a building with, 100 units. They feel lonely and isolated, and yet getting out in nature can completely change that perspective. And so maybe they don't need to do it every single day, though I'm sure it'd be great. The ability to have that rural resource in our world is of value to every individual. And that's just one example of the way I'd like to look at things. And I think we need to look at things in order to balance that ethical dilemma that we can run into, where if we're purely analytical and we don't have all the data, it looks like it's too expensive to serve these people here and more cost effective to serve these people over here. So what do we just move those people over here? And no, we need to get the tools and resources out to where everybody is so that we can gain that bigger picture perspective and make more ethical decisions moving forward.
And I would just love to reiterate a point that was made earlier in this discussion, where that doesn't necessarily mean that it's a duplication of the infrastructure that exists in urban environments for rural environments. And that has been really the first principle or the basic assumption of those attempts in the past. And we have ways to do it differently, very differently, but equally effectively in rural settings that have not been available. And similarly, we with our rolling out of technology to populations, we put technical literacy and technical education on that critical path. And then before you know it, when you have a population potentially with very low general literacy, let's say, the idea of technical education is so far out of reach and so tone deaf to the reality of people's lives. Instead, it needs to be like radio. People don't need a course to operate a radio. People didn't need a course to learn how to use a microwave. When we do our jobs as technology innovators, and this is one of the most massively impactful roles that AI can play, we have the potential to discover where people are cognitively from an educational basis, not only who they are as a demographic and a psychographic, but where are they right now dynamically in time, and then meet them there in exactly how they are communicated with, in their native language, in terminology they understand. And we can do that now, something that would be massively logistically out of whack, totally impossible prior to a very recent generation of AI that has been rapidly maturing only over the last 24 months. I get that it's a remarkable change in the art of the possible that we're taking fullest advantage of here on this team. So I want to offer both of you the opportunity to make a closing remark before we sign off. Doc or Doc. Oh,
Yeah, I
sorry.
was gonna say I'll go first in deference to Dr. Orley's pedigree, and give him the last word. But what I'd like to say is, the only constant is change. And so we're in a point of exponential change. I mean, change has always been exponential throughout history. But due to the nature of that, we're witnessing this rapid acceleration in our lifespans. Whereas even 100 years ago, it was much, much harder, even 20 years ago, it was much, much harder to recognize how rapidly things were changing. Whereas myself and my kids and all of us here are much more rapidly aware of, like you said, just in the last 2 years, this jump in AI that doesn't even compare to the last 40 years of AI development, right? And so I think that to a certain extent, being aware of that change can be very intimidating, and it can scare us and it can tamp us down. And I hope that we can experience that, observe that, and also take a deep breath and let that go, and get excited about this change and about the rapid pace of our own individual agency and ability to make lives better for ourselves and those around us, and do it very inclusively, where more and more of us are part of that conversation about how are we making and remaking the world around us today.
Yeah, and I second what Ryan said, and also reiterate what Heather just mentioned, that we are at the infancy of this new technology. And within the healthcare space, really the sky is the limit. Currently, we have implemented real-time bots that are recording conversations between doctors and patients and creating transcripts that are being aiding doctors in providing better care. We have chat bots that are taking medical histories directly from patients and providing those transcripts as well prior to medical visits. These are some technologies that are now being utilized, and we have so many more technologies that could potentially be incorporated into the doctor-patient interaction. And at this point, we don't really even know how far this technology can be taken within healthcare. And that's really an exciting, that's really exciting that, we really can take it very far. And I just want to say I'm very appreciative of Heather and the entire AI Mind Systems group for bringing me on board. And I'm really excited to continue to work with you and develop this new technology together.
Thank you so much, Dr. Orley, and thank you so much, Ryan. It's an honor to work with both of you. Audience, thank you so much for joining us today in a renewed hope for healthy, smart cities and rural health. Join us again the first Friday of each month for discussions on this specific topic. And we look forward to engaging with you as we embark on our ambitious challenges and the wicked problems that we're going after together. Thank you all so much. Until next time.